صديقة العمر وتلميذتي النجيبة رئيسة اسم الأطفال في معهد السكر دكتورة نرمين. يعني it's a pleasure for me to and honor to introduce نشوف اسمه Professor Stephen Victor Edelman from USA is going to talk about optimizing diabetes care in adolescents and establishing how to establish the transition. كلنا بنلاقي ان الترانزيشن فيز دي very difficult والعيانين بتوعنا ما بيرضوش يروحوا امراض باطنه فاحنا عاوزين نعرف تجربته ايه.
Well, thank you for that very generous introduction, and I'm very honored to speak before all of you at the Congress in Egypt, which was my first time. I love Egypt. I visited there many years ago with my family. So today I'm going to spend the next 35 minutes on how to optimize insulin therapy in adolescents with type 1 diabetes and talk about other important issues, how to control their diabetes, which I know is a tough role. I should let you all know that I developed type 1 diabetes when I was an adolescent at age 15. And this picture is from 1970 when I worked at a boys' camp in Los Angeles. Now, I still had my notebook that they gave my parents during the education course that I got in the hospital because I had diabetic ketoacidosis at that time. And this was the information and education page that they gave me with a typical diet. As you can see, some meat laden with fat around the outside, white bread, whole milk, eggs, canned green beans, and an apple. And of course, this was a room full of type 1 and type 2 diabetes, and they put everyone together. And I think you all know you certainly cannot do that for a successful education program. There's my urine test kit that I used at the time. In 1970, there was no A1C test. There was no glucose meters, no pumps or pens, no CGM. I was given NPH and regular once a day. And that was my regimen. And of course, you could imagine how poor my control was, giving NPH just once a day. I grew up, I went to UCLA. I wanted to become a diabetes specialist. I went to the Joslin Diabetes Center, where I really learned a lot of my diabetes expertise. And all of my colleagues here, most of them are retired, and I'm still working at the university and the VA and my not-for-profit organization. Now, this is an important slide to help traditional medical education. All of the research and teaching institutions do most of the basic work in discovering new drugs and devices for diabetes. Then they educate the healthcare providers. And the healthcare providers go on. I thought it was way too slow, and I tried to change things. So I had this idea of taking the important messages about living well with diabetes directly to the people most affected by this condition, people with diabetes and their loved ones. So I started a not-for-profit organization in September of 1995 called Taking Control of Your Diabetes. And over the next 25 years, we put on very large face-to-face conferences around the country, talking directly to the people with diabetes and their caregivers, mothers, fathers, sisters, brothers, kids. And I felt it was the fastest way to, and very efficient, to take information from the research and teaching institutions and educate people with diabetes and healthcare providers in parallel so they can now communicate with each other. And that's been a very successful not-for-profit adventure that I've had since 1995. Now, as you all know, COVID came along, and we had to shift silver linings in what we do due to COVID, because we did convert to virtual. Now we can memorialize all of our lectures. We can put in a lot of fun videos that can educate people, but also entertain them at the same time. We have a podcast, we have a video vault, and over on the lower right, we also have a CME program. And that particular program, you can see the young girl with some type of CGM sensor on her arm. This whole program is about Tableismab, the anti-CD3 monoclonal antibody that got approved to prevent people from going from stage 2 T1D to stage 3. Very exciting data. And now we actually touch 3 million people a month around the world. Everything we do is free. Please go on to the website. The website is on the upper left, tcoid.org. Lots of very good professional lectures as well. Now, I thought I would show you some data from the United States. This shows the percentage of adolescents with T1D reaching glycemic goals. So as you know, between ages 6 to 12, they changed the goal from less than 7 to less than 8, trying to be more realistic. And even doing that, only 46% of patients in this category reach their A1C goal. And then you go to most of the adolescents, which is ages 13 to 19, they changed the goal from 7 to less than 7.5. And despite raising the A1C goal, only 23% of patients achieve that goal. And the other thing I wanted to point out is this fact that a lot of healthcare professionals do not realize that when the A1C is high, you have a higher risk of severe hypoglycemia. And that's important because a lot of doctors, not specialists like yourself, but maybe more primary care doctors think, well, if the A1C is high, these folks are not at risk for hypoglycemia. But we know when the A1C is high, there's a lot of glycemic variability. And I think this picture says 1,000 words. It's basically a patient wearing a continuous glucose monitor where we overlapped each day of the week. And you can see that is basically unpredictable swings in glucose levels. And this is really not the case in folks with type 2, unless they're more insulin openic and they've had type 2 for a long time. But this is basically type 1 diabetes for adolescents and adults. And this is something that we all struggle with treating our patients in clinic every day. So this is one of my quotes, having type 1 diabetes for 50 years. You know, the best way to control type 1 diabetes is to stand perfectly still and not eat a thing, just like these royal guards in the UK. But obviously, that's not realistic, and not only for adolescents, but for anybody. So the first thing I want to talk about is continuous glucose monitoring. It is and has been the standard of care for patients with type 1 diabetes, including adolescents. Now, I know it's not as available in the Middle East, and I have some data, and I'm sure you know the data better than I do, but this is something that you've got to get. You've got to fight for it for your patients. And even if your patients' insurance companies don't cover it, they have to figure out some way to get one, whether through certain programs that allow them to afford it. So it allows for time and range metrics that we're going to talk about. It allows the most accurate way to evaluate long-term diabetes control versus the A1C. And I feel it is a way more important value than the A1C, the time and range. And it allows for a very efficient and focused way to identify and treat the major problems with diabetes control in your patients. I don't know about the Middle East, but in the United States, we have very little time to see the patients, and the CGM report allows us to hone in on the most significant problem. And very importantly, the CGM is the backbone of automated insulin delivery systems. These systems called hybrid closed loop systems, you probably, I'm sure you know about them. I believe the 780G is probably out in your area, but we have 5 different systems in the United States. But very importantly, the CGM is the backbone for patients on multiple daily injection regimens, which is still by far, even in the United States, the most common way type 1 diabetics take care of themselves, not pumps. So let's talk about time and range. It represents the time patients are between 70 and 180 milligrams per deciliter. And I'm sorry, you're going to have to change the millimolar in your own mind. It's really the first priority for your patients. And I mentioned that a second ago. And then we have to educate them not only how to set their alerts and alarms, which I'll talk about, but also how to respond to the trend arrows. And very importantly, bolus calculations are more than just counting carbs. We know that protein and fat will also raise your blood sugar, just slower. And we know that when you prick your finger and you get a glucose measurement with a self-monitoring of plasma glucose, it only tells you what your blood sugar is at one point in time, with no idea what direction you've come from or what direction you're going. So you can imagine how hard it is to control diabetes. And of course, trying to get the A1C below 7, and very importantly, reduce the glycemic variability. That's almost as important as getting the average glucose down. And you should try to use a regimen that mimics what happens in the non-diabetic state, either insulin pump therapy or a multiple daily injection regimen with a very flat, long-acting basal and fast-acting for meals. So you're all familiar with this chart. This is the targets for time and range for people with type 1 diabetes. We have more stringent targets for women who are pregnant. We have less stringent targets for the elderly with cardiovascular and comorbid complications. But basically, time and range in green is 70% or more. Now, each percent represents 15 minutes. So 70% represents 17 and a half hours a day. So that's basically a lot of time to even be out of range and still have reached this goal of greater than 70%. And greater than 70% relates to an A1C of about 7.0. So these goals were not just pulled out of a hat. They were thought about by major consensus conferences. The second most important value, well, actually maybe the first, is time below range, less than 4%. And then time below very low range, less than 1%. And it's important to note that if you're reading a download and your patient has 4% time below range, and since every percent represents 15 minutes, that means for the length of that download, on average, their blood sugar is below 70, 1 hour a day. So it's important to realize that and to have conversations with your patients. Now, I'm not going to get into a plethora of data that is building, that it shows that the better your time and range, as you can see along the bottom, as the time and range improves between 70 and 180, the frequency of retinopathy goes down. This is very good data that was pulled from the diabetes control and complication trial, that they didn't have CGMs back then, but they did have a ton of finger stick values as patients for 10 years were brought in for oral glucose tolerance tests in the clinical research centers. And it also is related to reduction in nephropathy as well. And so this is important, and we're trying to impress our regulators, the FDA, how important time and range is and how it's related to complications. And the glycemic variability I've mentioned several times. You can see in the upper curve, these patients have a lot of up and down bounce, a lot of highs, a lot of lows. You can see I've circled them with a red circle. And down below, you can see a patient who's doing much, much better, not having much glycemic variability. The standard deviation, coefficient of variation is low. And these two patients have the same A1C. So it's important to realize that the A1C is not the best test. And when you look at a CGM download, which we'll do in a second, the measurement of glycemic variability is extremely important. And I think for our patients, we're trying to avoid extreme high and dangerous lows. And I'm sure many of you have patients that have had a bad low blood sugar, and now they're scared to death to get their diabetes control at a better level. And so this is what CGM can help address. So here's a typical download. This patient is not really ideal, but and I go through these things with the patient, with the adolescent next to me. And I talk about the average blood sugar. There's the goal, less than 155. I look at standard deviation, which is a degree of variability. The goal is less than 50. The estimated A1C we call the glucose management indicator, less than 7. And then we go to time and range. Goal is greater than 70. This patient is 64. And hypo, time below range, is less than 4%. This patient is 5, and time very below range, very low, below 55 is less than 1%, and this patient is 3%. So basically, this patient is below 55, 45 minutes a day for the length of this download. So at first, you might say, this guy's doing pretty well. Look at that average glucose. Look at that estimated A1C, 6.9, pretty darn good. Time in range isn't that bad. It's approaching 70%, but he has a lot of variability with a standard deviation of 71 and a lot of lows. So I would focus my visit, if I saw this download, on the lows and find out what's going on, try to reduce those lows. And that's what I would spend my valuable limited time in clinic. Now, the other important part of the CGM download, not this patient's, this is a different patient, is the 24-hour modal day. And once you look at these, and it's great to look at these once again with your patient sitting right next to you, you can see in literally 5 seconds what's happening. You can see that from 8 o'clock in the morning, the rest of the day is doing pretty darn good, or she. But something's happening between midnight and 8 a.m., where the average is extremely high and a tremendous amount of variability. So it turns out that this patient is a policeman, and he has the graveyard shift. He works from midnight till 8 a.m. And of course, he's running around working, not paying attention to his diabetes. And so then we the main thing we did for this patient was to send a letter to the police captain to try to get him to switch to a daytime shift. But in any case, right away you can see what happens, what the area to focus on. And we did some measures to try to help him improve his diabetes overnight. Now, what about this download? The first thing you look at, you start scratching your head, you say the estimated A1C is 9%, and the average glucose is 212. His time in range is terrible. I don't have it on the slide. But then what you have to look at with a thing like this is look at where this patient set his alerts and alarms. So you can see his lower alert is set at 80, which is fine. His high alert is 390. Most providers, including endocrinologists, do not talk or pay attention to where a patient sets his or her alert alarms. Now, you might get a lot of pushback from your patients. Oh, I don't want to be bugged. They turn the high alert off. But if you turn that high alert off, you're missing one of the most important features of a CGM. And I try to talk my patients into the fact that these alerts are your friends. They tell you, depending where you set it, you get alerted long before you get to the 180 range. So you can improve your time and range. And some of these continuous glucose monitors do have the ability to have alerts with different times. So for example, during the day, a patient may be a little bit tighter with an upper alert at 180, even 150. At night, you can widen it up so they don't get bothered. So I want to bring that to your attention when you're seeing patients. Now, we've talked about alerts and alarms. It's extremely important. And I can tell you that when a patient lowers his or her upper alert, let's just say from 180 to 160, you can improve the time and range, the GMI, and the glycemic variability just by changing the upper alert and, very importantly, teaching your patients how to respond. And the second thing you need to spend time with that most providers do not do is how to respond to the trend arrows. Very important, not only for behavior modification, adjusting what they're eating, adding in a little exercise, but also dosing insulin. So here's a glucose meter that has one value at one point in time, 220. Here's a continuous glucose monitor that shows 220 with 2 arrows going down. Here's a continuous glucose monitor showing a blood sugar 220 with 2 arrows going up. This is quite a different situation. On the upper download, you're going to not give any insulin, and on the second download, you're going to give insulin because you see that your blood sugar is 220, and you're going to give more insulin than you normally would because the trend arrows are going up. And this is why people who use finger stick, self-monitoring of plasma glucose, are all over the place because they don't know if they're going up or down. So let me tell you a little bit about the trend arrows. I was able to do a study with my colleague Jeremy Pettis, who also is a great endocrinologist with type 1 diabetes himself. And we asked 222 successful CGM users with type 1 diabetes, what's the most important feature of their CGM device? And these were folks that were on CGM at least a year. The mean A1C for the group was 6.9 with minimal hypoglycemia. So that's what we defined as successful. They loved the real-time trend arrows and the real-time high and low alerts. And that's important because they realized how important it is. And the least useful feature for them was the retrospective download. The retrospective download is for all of you, and it is instructive to go through that when your patient's in clinic. So in this study, we gave patients different scenarios, and I'm only going to show you one scenario. On the left, we told patients that their blood sugar was 220. We told them they had a horizontal trend arrow. We told them they're not going to eat or exercise in the next 4 hours. And we asked them how much insulin would they need to correct from 220 to 120. The average dose was 3 units, meaning that the average correction factor was like 1 to 35. Then we gave them the same scenario, except they had 2 arrows going up. Once again, no food, no exercise for the ensuing 4 hours. And the mean dose that they had was 6.8 units. Now think about that. That is a doubling of the insulin dose based solely on the trend arrows. So here's the results of the study. You can see when the trend arrow was straight across, I just showed you the mean dose of the 222 subjects was 3 units. 2 arrows up, I've already showed you 6.8. 2 arrows down, the mean dose was 1.5. Many of those patients said, I'm going to wait and not give any insulin until the trend arrow straightens across. So we came up with this sheet, patient instruction, and we published this as well, what to do, how to adjust their insulin dose based on the anticipated glucose in 30 minutes. So if the diagonal up, that means that the glucose is rising 1 to 2 milligrams per deciliter per minute. In 30 minutes, it's going to go up 30 to 60 points. So we thought a conservative suggestion would be to add 50 to their current blood sugar and then correct for that level. So for example, if their blood sugar was 200 with a trend arrow diagonal up, then they would correct for a blood sugar of 200. We know that 1 arrow up, they would add 75, 2 arrows up at 100 to their current blood sugar. So if their blood sugar was 200 and they had 2 arrows up, they would correct for 300. And then on the way down, we thought the most conservative thing to suggest would be not give any insulin, no matter what their blood sugar is, unless it was really high, and wait until the trend arrow becomes horizontal. And if it becomes horizontal for 3 cycles, 15 minutes, then they would correct if they're still above 180 or 200 or whatever instructions you've given them. If they level off at 150, that might be perfect for them. So I'm happy with their Sanofi folks, and they can distribute them. So let's talk about advances in basal insulin. I told you I was put on NPH and regular once a day. On the left-hand side, you can see NPH is really not a basal insulin. I know that it's used quite a bit in type 1 diabetes, but it is not the best choice. And I realize there are reasons why patients are put on that. Insurance reasons, access, things like that. Then came along Glargine U100 and Detamir in the middle, and that was definitely an improvement. But I think most recently, in at least the last decade, we got insulin Degludec and insulin Glargine U300, which I think represent a tremendous advance, especially for type 1 diabetes, because we want a flat, prolonged basal insulin, take away some of the variability that we see with the older first generation basal insulin. So what has been shown in clinical trials with these two insulins? And as you know, they're made by two different companies. They're competitive companies, lots of studies. But in general, both of them show less intra-subject variability, less hypoglycemia, less weight gain, flat, stable, and prolonged action greater than 24 hours. I want to tell you all that when you use either one of these insulins, because they have they have a stretched out PK/PD, sometimes it takes 3 to 5 days to reach equilibration. You've got to tell your patients that they may have high blood sugars for the first couple of days until you reach equilibration, to give a few more correction doses, but just tell them that this is normal. A lot of patients, if they're not told that, they think that the insulin is not very good, and then they stop it, and that's not good at all. And typically it's 1-to-1 conversion. In the earlier studies with U300 glargine, they needed more U300 glargine than the previous U100 glargine dose, but that's definitely not the case in other studies. So I think it's just safe to start off 1-to-1. And both insulins come in very easy to use pens. Now, I want to, before I go on and tell you more about the second generation basal insulins, I was lucky enough to be an author in this study called the SAGE study. It looked at regional differences in glycemic control, hypoglycemia, and disease management in adults with type 1 diabetes in 5 different regions around the world. And there they are: Latin America, Western Europe, Eastern Europe, Middle East, and Asia. And this was published in Diabuddy in 2019. And I'm sure things have changed since then, but at least this paper is not 10 years old. It's only less than 4 years old. And this slide shows the primary endpoint, which is the percent of patients less than A1, with an A1C less than 7%. See, Western Europe is 27%, and East Asia is 21% of patients, and then Middle East, it's 18.9%. Realizing that diabetes control is tough in the Middle East for a lot of different reasons. And of course, you know them all better than I do. When you look at the insulin treatment for type 1, let's focus in on the first generation and second generation insulins and premix. So if we go to the right here under Middle East, 69% were using the first generation, 0.2% were using second generation, and 16.1% was using premix. Premix is probably the worst choice in treating type 1s. You've got to be able to adjust the basal and the fast acting separately. And once again, I'm not here to criticize. I realize that that may be all that's available to your patients. And but that is probably the worst way to treat a type 1. And you can see the rates are much lower in other countries. Not that they're doing it the right way, but I do believe that premix is not the way to go. And so I've said enough about that. Okay, let's talk about CGM. Well, if you look at CGM use in 2019 in the Middle East, 2.5%. The single most important thing for your type 1 patients, no matter what kind of regimen they're on, pump or multiple daily injections. And Western Europe, of course, the availability is much greater. You can see it's 46% of the patients are able to get are wearing a CGM at that time. And that was 4 years ago. And we do have a lot of competition in the CGM space, at least in the United States. We have the Abbott device, we have the Dexcom device, we have the implantable sensor made by Eversense, and we have Medtronic sensor as well. Now, I want to just go through a few studies as I finish up my talk. And this is the InRange study. And once again, I was very fortunate to be involved in this study. It was the very first study to use time in range as the primary endpoint. So hats off to Sanofi for taking this first step. It was conducted, we started this study just before COVID, and COVID slowed down our research activity quite a bit, but we did finish the study, and the results are quite instructive. And let me just show you the summary of the results. Primary endpoint was time in range. They compared insulin degludec versus U300 glargine. no difference in time and range. And I did not expect to be any difference in time and range. They're both very good basal insulin. Now, I want to point out something else. Now, these patients volunteered for the study. They were monitored by endocrinologists, diabetes savvy endocrinologists, and the time and range they can get was around 50, 55%. Now, it's important to note that CGM was used in this study only blinded in the beginning and at the end. These patients did not use CGM to monitor and adjust their insulin during the study. Very important point, because this 50 to 55% time and range, remember the goal is above 70, represents about as best as you can get with a very good multiple daily injection regimen without the use of CGM. And we know from clinical trials that you add CGM in and you're going to be between 60 and 70% time and range just by having that data available to the patient on a day-to-day basis with alerts and alarms and education for trend arrows. What's the main secondary endpoint was glycemic variability. And you can see, once again, they use coefficient of variation about 40 to 41%. No difference between the two insulins. And remember, the goal for coefficient of variation is less than 37. And so, once again, they're not quite at goal, but this is about as best as you can get without the use of a CGM. Now, what else came out of this study I think was very impressive. During those 2 weeks in the beginning and 2 weeks at the end where they had blinded CGM, you can see that the CGM picked up a tremendously higher rate of hypoglycemia than the patients did at the same time pricking their finger 4 to 5 times a day with self-monitoring of plasma glucose. So you can see how much hypo is being missed when you're just using 3 to 4 or 5 finger sticks a day, if we can get our patients to even measure. So 3 to 5-fold higher. And that was very instructive that came out of this study. Now, what about the OneCare RealWorld study? This study looked at the effectiveness and safety of glargine U100 in comparison with degludec U100. Well, I'm sorry, glargine U300 versus degludec U100. And they looked at CGM in adults with type 1 diabetes with suboptimal control. It was a very simple study. Adults with type 1 diabetes, and they were put on they were switched from their previous basal to U300 or insulin degludec. And I think once again, if you look at the overall, let me just go back here. On the left-hand side shows the full 24-hour day. They looked at the percent time and range, and you can see that they were very similar when they looked at 70 to 180 and another category 70 to 140. Not statistically significantly different, but I think what was interesting is that when they looked at just the nocturnal range between midnight and 6 a.m., that the U300 glargine had a greater time and range in both categories, 70 to 180 and 70 to 140, and they also had less time below range and better variability. So it looks like, at least in this study, there was more time and range overnight. And remember, when you have more time and range, you have less time in the high and less time in the low range. And what was true with both degludec and U300 glargine is that they reduced severe hypoglycemia with a relative risk of 76%. And you can see that p-value of 0.0003. So both second generation basals protected against severe hypoglycemia. The last study I'll show you is the Ultraflex study. It was a very complicated study and took a tremendous amount of work, but it was a randomized single center 4-period crossover study, including adults with type 1 diabetes on MDI and an A1C less than 10%, but above 8. Now, in this study, I'm not going to go through the protocol in detail, but you can just listen to me. They took type 1s and they gave them either 100% of their glargine U300 dose or their degludec dose, and then they exercised them late afternoon for an hour, and they looked at hypoglycemia in the ensuing 24 hours. So every patient that started off, and this is basically the results. You can see that when you look at you on the right-hand side, whether you use glargine U300 or degludec, if you use 75% of the dose in the morning, that those patients had reduced time below range, less than 70, for the 24 hours post-exercise. Now, if you look at the 100% dose, that it looks like the glargine group, U300 glargine, had less time below range than the degludec group that used 100% of their typical dose. So basically, the conclusion in this paper was that they're both reducing your insulin to 75% in the morning is a good thing for diabetics if they're going to exercise in terms of reducing hypo the next day. But if you do spontaneous exercise, U300 glargine perhaps will be a little safer in preventing against hypo. So in finishing my talk, I'm not going to talk about hybrid closed loop systems, but really insulin dosing should be based on the predicted glucose value 30 minutes into the future. But you should also include insulin on board, duration of insulin action, carbohydrates on board, anticipated exercise and sleeping. That's exactly what these hybrid closed loop systems with automatic insulin delivery delivers. We have 5 different systems in the States. And one thing I'll show you, a typical download, you can see that the average drops and the standard deviation gets very tight overnight. A typical download from someone on a hybrid closed loop system, and very importantly, extremely low hypoglycemia with an A1C of 6.9%. This is a patient of mine. He got tired of using his pump. He went on an MDI regimen, U300 glargine and Lysopro before meals. And just to cut to the chase, he's a very engaged teenager. His time in range is 89%. He has very little lows, in fact, no lows. And he wears a Dexcom G7. So I think the important point about this case is you don't need to be on the fancy technology to have good control. You do need a CGM to have a good A1C with very little hypoglycemia. So with that, I'll stop and we can open it for questions and answers and have a discussion. Thank you very much.
Thank you very much, Professor Edelman. It is very elegant talk, but I would like to ask your experience about 2 things. Adolescence, as you know, is a very difficult period of age. How can you afford having these adolescents go to medical clinics, leaving diabetic children clinic? How can you convince them? Another thing, what is the best time for giving long-acting insulin for these adolescents, because they have a very erratic way of living, especially in holidays?
Yes. Can you hear me okay? Can you hear me?
Yes, I can.
What was that?
Yes, I can hear you, yes.
Okay, thank you.
Okay.
I just wanted to make sure. Well, thank you for inviting me to speak at your conference. I'd like to be there in person. I've been in Egypt before. I love the country. People are nice. They love kids. And I hope to come back someday. Well, you know, I'll talk first about the transition clinic. And, you know, it's an age-old problem where in the United States, and probably similar in many clinics in your country, you know, children get treated very nicely in the official pediatric diabetes clinic. They're cared for typically up to the age of 18. They not only have a pediatric endocrinologist, but they also have diabetes educators that are specialized and educated in pediatrics. They got pediatric dietitians, social workers, psychologists. And there's been many, many papers published on the transition from, kids and adolescents to adults. And I can tell you, it's not easy to set up a successful transition clinic. So one of the things I've seen in my experience is that is a setup. Well, let me just say that a lot of the data show that when the transition to adult endocrine clinic is not done correctly, there's data to show that the A1C goes up after they, quote unquote, leave the pediatric endocrinologist. The incidence of DKA goes up. The hospitalization goes up for any reason, including hyperglycemia, the length of hospitalization, and of course, the cost and the emotional and behavioral benefit detriments that happens when people switch. And as you know, many patients don't want to leave their pediatric endocrinologist and the clinic. So what I've seen and what's successful in our clinic, and we're not always successful, I don't want to make it sound like we have a perfect system, but it comes down to preparation, not only preparation of the patient and his or her parents. And what does that preparation take? Well, expectations. Self-care education is important because in the United States and probably in your area of the world, once you get to adult clinic, you better be very savvy on self-care strategies, whether you're on multiple daily injections or if you're on a hybrid closed loop system. And that preparation starts early. So that's basically education. Now, on the provider side, there's no question that there's a lack of communication between pediatric endos and the adult endos that they send their patients to. I'm at a big university. We have a system set up where there's communication at least 6 months before the transition. And not only is the information set about the patient, what kind of background, if they had any particular issues, what their A1C is, what kind of regimen they're on. Very importantly, if it's a trouble patient with many control issues, those are the ones that are going to get into trouble during the transition. So we keep a closer eye on those. And very importantly, this sounds very simple, but there has to be an appointment made. If you just tell your pediatric patients, adolescents, you need to make an appointment with this adult clinic, it typically doesn't happen at least half the time. And then there's a big delay in someone being seen until something negative happens, like admission for diabetic ketoacidosis. So it comes down to robust preparation strategies and the handoff between the pediatric and adult care services. That's key. And ideally, this is an ideal situation where you have a specific clinic, pediatric clinic and the adult clinic, and maybe in the different floor, maybe even on the same floor. And so it's a really specific clinic. And typically we have someone who's a pediatric and adult endocrinologist see these kids during their transition or up to the transition. Now, and we also have a Diabuddy system where we take an adult patient who's done very well, become a Diabuddy to a pediatric adolescent patient who's approaching and going through and finally went through the transition. And sometimes having a person with diabetes who's done well as kind of a support person for the younger patient goes a long way. And we make sure the Diabuddies are educated well. And lastly, before I finish, there's lots of administrative and financial pressures. It's so hard to set up a transition clinic. We have the Department of Pediatrics and the Department of Medicine. Who's going to pay for it? Who pays for what? who pays the salary of the endocrinologist that works in the transition clinic? You know, is it a peds endo? Is it adult endo? And you don't have to be double boarded in both those situations. You know, you just need to be knowledgeable about both the different age groups. So it's very difficult, but it comes down to preparation on the patient side, the provider side, the clinic side, and then close monitoring during the transition. So that's a long-winded answer to your question, but that's sort of a summary of my experience and some of the research I've reviewed in preparation for this conference. Now, there was a second question. Would you mind repeating that? Or if you have any questions relating to what I just said, please ask that now.
Thank you, Professor Stephen, for this elegant talk and quite clear information. But I want to ask about a slide that you, sir, showed it. It shows increased attacks of severe hypoglycemia with increased level of glycated hemoglobin. What is the mechanism of that? Is it the erratic eating of adolescent or what? Thank you.
Yeah, that's a great question. And we pretty much have understood that if you take patients with type 1 with high A1Cs and you look at their CGM, there are typically lots of variability. And variability means lots of highs, giving you a high glycosylated hemoglobin, but also lots of lows. So as you know, taking care of patients yourself, people that have very high A1C typically have problems being regular in their medication, with their exercise, the time of the insulin administration. So the basic answer is variability. And that explains the hypo, in addition to the hyper, giving rise to the high A1C.
Thank you, Dr. Edelman. Thank you. Thank you for your elegant talk. I know that it's very hard to manage the adolescent with the rebellious attitude, and we wanted to know a best way to transfer to adult. Anyway, I think we have to talk about it among ourselves. If there is no question from the floor, or there is a question? There is no question, right? No? Okay. Thank you very much, Dr. Edelman. Hope to see you soon here in Cairo. Thank you very much.
All right. Thank you.
طبعا نشكر حضراتكم على الصمود، واحنا بس عندنا هنكمل السيشن اوف ذا اوبيزيتي كوز اور ايفكت. وطبعا يسعدني اقدم I'll pass the mic to دكتورة منى عشان تقدم.
It's with the pleasure that I introduce Dr. Omnia Magdi, Assistant Professor of Pediatrics, Alexandria. And فرصة ان احنا to congratulate her على جائزة الجامعة التشجيعية